adult-onset cystic acne, rapid scalp hair thinning, and prostate hypertrophy. These severe manifestations occur when high concentrations of androgens act directly on target tissues. Yet, looking at this split-screen clinical dossier reveals a clear contradiction. The profile on the left shows high total testosterone but no symptoms. The profile on the right shows severe alopecia and hirsutism, even though their total testosterone remains completely normal. This presents a specific clinical problem. Severe androgen-driven diseases regularly destroy tissue without leaving any trace of elevated hormone levels in a standard blood draw. Total testosterone is a passive metabolic reservoir circulating in the blood. It does not measure actual biological activity at the cellular level. Relying on these systemic metrics creates a diagnostic blind spot, leaving many patients, particularly in female endocrinology, without a valid explanation or treatment for their symptoms. The true drivers of these pathologies do not exist in the bloodstream. They operate in localized tissue microenvironments and hepatic buffering systems. To accurately map the disease, we must analyze three pillars of androgen architecture: sex hormone binding globulin, peripheral enzyme conversion, and receptor genetics. Treating the standard blood panel fails. Successful intervention requires intercepting precise receptor kinetics directly at the specific tissue level. The liver synthesizes sex hormone binding globulin, or SHBG. This is an active regulatory protein that captures and envelops circulating androgens. The binding hierarchy shows DHT at the very top with the highest affinity, followed by testosterone and estradiol at the bottom. This establishes the free hormone hypothesis. Any hormone bound to SHBG is biologically inert. Only the unbound fraction, roughly 2. Because DHT possesses the highest binding affinity, it is the most tightly sequestered hormone in a healthy metabolic state. SHBG is not a static metric. Its production is highly volatile, dictated by a patient's metabolic state. As insulin resistance develops, rising insulin levels suppress SHBG secretion. This dynamic creates the perimenopause paradox, a metabolic perfect storm for female patients. This graph tracks perimenopause. Systemic estrogen falls, removing the stimulus for SHBG production. Consequently, SHBG plummets. Mathematical logic dictates the result. Because DHT was tightly bound, falling SHBG unleashes a flood of free DHT, even as the flat baseline of total testosterone remains completely unchanged. The target tissues are now saturated in a toxic, hyperandrogenic environment. A standard serum assay will entirely miss this cement. A metabolic drop in SHBG produces the exact same cellular destruction as a massive systemic surge in free androgens. To see how that free hormone operates, we have to look past the systemic bloodstream and zoom deep into localized target tissues, like the dermal papilla or the prostate gland. The unbound testosterone molecule bypasses the blood vessels and penetrates the outer boundary of the target cell. This biochemical schematic illustrates what happens next. Stationed inside the tissue, the 5-alpha reductase enzyme utilizes NADPH to strip a double bond from testosterone, converting it into DHT. This occurs exclusively inside the target cell. Nothing leaks back out. DHT operates strictly as a paracrine hormone. Measuring serum DHT on a blood test provides no actionable data. It fails to capture the extreme hormone concentrations accumulating inside the cells. This localized amplifier drives normal external genitalia differentiation in embryos, and later in life, it drives pathological prostate hypertrophy in adults.
In severe hyperandrogenic conditions, the standard enzymatic pathway is not the only mechanism producing DHT. Certain tissues can activate a secondary route, known as the backdoor pathway. It bypasses the usual steroidal intermediates entirely, generating DHT directly from placental progesterone. 5-alpha reductase enzyme acts as the ultimate cellular amplifier. It takes a systemic whisper of testosterone and turns it into a localized roar of DHT. The newly minted DHT molecule travels deep into the target cell's cytoplasm, where it encounters the androgen receptor. Compared to standard testosterone, DHT interacts with the receptor with brutal efficiency. It has double the binding affinity, and a dissociation rate 5 times slower. It essentially locks the receptor on. This ligand binding initiates a precise sequence, forcing the receptor to shed its protective heat shock proteins. The newly liberated ligand receptor complex translocates through the nuclear membrane and enters the cell nucleus. Its objective is to bind to specific androgen response elements on the DNA and dictate gene transcription. This map shows the androgen receptor structure, the NH2 terminal, DNA binding, and ligand binding domains. Look at the NH2 terminal containing variable CAG repeats. An inverse correlation governs this. A short chain pulses with high activity, while a long chain barely emits a signal. This genetic variance dictates the severity of the patient's symptoms. Shorter repeats create hypersensitivity, causing aggressive pathology even with minimal DHT present in the tissue. This explains why 2 patients with identical hormone levels and identical lifestyles can present with completely different disease profiles.
The androgen receptor's genetic structure serves as the final arbiter. It decides whether a hormonal signal is safely ignored or weaponized against the tissue. With the microarchitecture identified, we can formulate precise clinical interventions based on this data. Prescribing systemic testosterone blockers is a blunt, outdated instrument. It is highly ineffective for diseases occurring within specific tissues. This flowchart demonstrates the exact mechanism of 5-alpha reductase inhibitors, such as finasteride and dutasteride. They form a barrier at the enzyme layer, halting the conversion of testosterone to DHT. These drugs leave the systemic testosterone reservoir largely untouched. They only neutralize the localized paracrine amplifier. But advanced pathology presents a different reality. If the androgen receptor has already fired continuously for years, it has likely suppressed downstream regenerative pathways. The Wnt beta-catenin pathway is a prime casualty. Prolonged androgenic signaling forces this critical growth pathway to shut down entirely in the dermal papillae. In these advanced cases, blocking the enzyme is insufficient. The downstream signal must be forcefully restarted. Targeted therapies like cold atmospheric plasma and injectable platelet-rich fibrin serve as medical workarounds, bypassing the androgen receptor entirely. These treatments deliver growth factors directly to the miniaturized follicle to artificially restore anagen signaling and compel the tissue to regenerate. Mastering the localized cascade, from the hepatic SHBG buffer down to the receptor's genetic code, allows clinicians to stop chasing systemic anomalies and effectively conquer androgen-driven disease.